So good afternoon, everybody. So I will talk really about our long-term follow-up study. ASD is a highly heterogeneous disorder, we all know, with great variability in the severity of autism symptoms, cognitive ability, and language skills. Long-term outcomes of ASD can range from having continuous severe social communication and functional impairments, but some have mild difficulties and nearly typical functioning in adolescence and adulthood. And if you look at the literature, very few long-term studies on outcome trajectories in ASD have been published. And the concept of optimal outcome is really intriguing and controversial. Is it in fact possible to grow out of autism? And if so, what are the characteristics of those who do? Are there any predictors at toddlerhood for this favorable outcome? So if we look at the literature on this subject, retrospective studies on optimal outcome, and all of those listed here are from the same group, and they actually examined 34 adolescents and adults who had no difference in socialization, communication, and language subscales scores between them and typically developing. And also in academic skills, they have no difference from typical peers. And what the characteristics were was that they no longer met diagnostic criteria for ASD by middle childhood by ADAS, and they had an average IQ with average adaptive skills, and they were in regular classroom without extra assistance, and some had mild social difficulties, attentional problems, and a little bit of stereotypical behaviors, but they were not actually fulfilling the criteria for autism. And the long-term follow-up studies, one of them is of Anderson and Lord from the ADOS. They followed children from 2 years to 19, and they described 9% of this cohort that didn't meet criteria for ASD at adulthood, at 19. And there was another study from Sweden following 50 males with Asperger's syndrome from younger age, a diagnosis done at a younger age, and a small group of adults, 22% of them, no longer met diagnostic criteria for ASD. They all had average IQ and had friends, were living independently, and all but one was were employed. And if we look also at the literature about predictors of better outcome, one of the studies that followed children diagnosed at 4 years of age until 26 years of age, they found that very specific behaviors in the beginning, responsive to joint attention and early childhood language, predicted some kind of composite measure at adulthood, social functioning, and independence. And Anderson, from the study I mentioned before, she reported that improvement in RRB, in the restrictive and repetitive behavior, after 1 year from diagnosis was associated with better outcome. And also the type of intervention the children received, mainly ABA, and the intensity of the intervention were also associated with better outcome. And also from the previous studies, Fine and Al and Orenstein and Al, it's from the same group, they found that parents who reported earlier symptoms and earlier parental concerns and earlier and more intensive intervention, especially ABA therapy, were also associated with this better outcome. So we decided to conduct a research, a long-term prospective study, and we followed toddlers diagnosed with ASD at our autism center, and from 2 years of age until adolescence. And we also had extensive birth, medical, cognitive, behavioral variables that were obtained at toddlerhood that actually enabled us to search for predictors of outcome. So what were the aims of our study? First of all, to compare the trajectories in cognitive ability, in autism severity, and adaptive functioning in 3 groups in adolescents. One, we call them best outcome. I'll describe their characteristics later. The second, high functioning ASD. And the third, low functioning ASD. And the second aim was to compare comorbidities of ADHD and anxiety for these 3 groups, and also compare birth risk factors, neurological and medical condition, and toddlerhood between these 3 groups, and to search for characteristics at toddlerhood that may predict outcome trajectory and membership in one of these outcome groups. So who were our participants? Children who were diagnosed in our center between 2002 to 2009, prior to age 38 months, and all have had cognitive evaluation at the time of evaluation. And finally, our cohort consisted of 63 males and 5 females. Age of initial diagnosis was 2 years and 2 months, and mean age at adolescent was almost 14 months, and mean time of follow-up was almost 12 years. Okay, so our participants actually were divided to 3 groups, as I said before. The low-functioning group had IQ below 80, and ADOS scores above 3, which is considered within the spectrum. And we had 43 of the participants belonging to this group. The high functioning IQ was above 80, and ADOS was also above 3. And we had 14 of those. And the best outcome group consisted of 11 participants. IQ was above 80, and ADOS was below 3, at adolescence, of course. And at the time of diagnosis, we used for ASD diagnosis the ADAR, the ADOS, and clinical assessment. For autism severity, the ADOS calibrated severity scores. For cognitive assessment, DQ, the Mullen. And for adaptive skills, the VABS. And as I said before, we had medical and neurological exam, including a lot of birth risk factors and medical conditions. We'll discuss them later, and abnormal neurological findings. And at adolescence, all the children had SRS for parents' description of their autism symptoms, the ADOS 2 severity scores, cognitive assessment, adaptive skills, and we also examined the comorbidities with specific questionnaires for ADHD and anxiety, the Conners and the SCARED respectively. And we also obtained many, many other measures that we haven't yet even looked and examined, but this is for the next presentation. So what were our results? So first of all, looking at the demographics, the age at T2, the age at T1, the age at T2, and parental education were not different in the beginning. And when we look at T2 characteristics of the cohort, then in terms of IQ, the best outcome and high functioning ASD had a significantly higher IQ than the low functioning ASD. The best outcome group had less impaired social communication, that's according to our division than the two other groups on the ADOS and SRS. And the best outcome group and the HFASD had better adaptive skills than the low functioning ASD. So although we split the groups according to certain criteria, they still varied in these results. And what were the trajectories? Let's look first at the IQ outcome. And you can see something very, very interesting. The low functioning group actually decreased in their IQ or cognitive ability along the years. The high functioning group, they actually stayed the same. They didn't differ. And the best outcome group significantly increased their IQ scores from T1 to T2. And looking at autism severity, the low functioning group showed a significant increase in severity of both the ADOS social skills, of both also social affect and the restrictive and repetitive behavior. And the best outcome group showed really a decrease, significant decrease in the social affect and also in the RB on the left-hand side. And the interesting part is the HFASD group didn't show significant change for both the social affect and the RB. So completely different outcome trajectory. And the most interesting part is the adaptive skills. And you can see that the best outcome and high functioning ASD both showed significant increase in VABS composite scores from T1 to T2, but there was no significant change noted for the low functioning ASD group. So again, completely different outcome. So what were the most recent educational placement of the three groups? So the low functioning group was mainly in ASD classroom or ASD school for autism, and the high functioning mostly in regular class with aid, and the best outcome group mostly regular education without an aid. So again, different even in educational setting. And then we looked for predictors, or what was different early on between those three groups, and looking at DQ, autism severity, and adaptive skills. What you can see is that at toddlerhood, better DQ scores and less impaired social affect were noted for the BO and HFASD group, but not for the LF-ASD group, meaning that better DQ and less impaired autism is associated with better outcome. And then we thought to make it more, to search for more specific predictors or differences. And we looked at the ADOS items specifically and saw whether they are different or not. And what we found are that specific behaviors, frequency of vocalization directed to others, the showing behaviors, pointing, and facial expression directed to others, and response to joint attention were all less impaired for the best outcome group and HFASD group. And then we looked at comorbidities, because we are looking at comorbidities as inherent traits, because although we see them later, they probably, the child has genetic predisposition to that. So we looked at T2, corner 3 scores, and inattention and hyperactivity impulsivity. And what we found that inattention score were significantly lower for the best outcome group than for the two other ASD groups. And the percentage of participants with ADHD, according to parents and teachers' corners, meeting the cutoff for ADHD, was highest for the low-functioning ASD. And then we looked at anxiety measures using the SCARED. And using the total score of the SCARED, we didn't find significant differences. But when we looked at how many of the cohort in each group reached the cutoff for at least one SCARED subdomain, a significantly higher percentage of high-functioning ASD met cutoff criteria for one anxiety subdomain than in the best outcome group. You can see that 62% versus 27. And then we looked at different medical and neurological findings in the beginning, and we looked at assisted reproductive technology, prematurity, and low birth weight. All of them were higher, significantly higher in the cohort in comparison to the general population, but there was no significant differences between the group. And then we looked at medical condition, microcephaly, macrocephaly, developmental regression, and history of ASD in the family. Again, all of them were significantly higher than in the general population, but no significant difference between those three groups. And then we looked at abnormal neurological examination, mostly hypotonia. Hypertonia was not present at all, but hypotonia was present in high percentage, and differences in deep tendon reflexes and hyperlaxity of joints. But again, there was no significant difference between the groups in any of these measures. And then we wanted to look for predictors of outcome, and we used linear regression model for prediction of membership in one of the three defined groups. And having higher DQ and less impaired showing behavior at T1 was associated with better outcome, meaning that DQ at the beginning was significantly and positively correlated with better outcome, and better showing score significantly and negatively associated with better outcome, meaning better showing, less better outcome. And higher DQ and better showing behavior actually predicted membership in a group with better outcome at adolescence. The pointing, the T1 pointing scores show the trend for statistical significance. And the total model explained 27% of the variance. So if to summarize our study, although the majority of the study population remained within the autism spectrum, there was a group that made impressive progress in several functioning domains. We found different trajectories for the three defined groups. The low functioning group showed a decrease in cognitive ability, an increase in social affect and restrictive and repetitive behavioral severity, and no change in adaptive skills standard scores along the years. The high functioning ASD group showed stability in cognitive ability and autism severity, but they improved in adaptive functioning along the years. And the best outcome group improved significantly in cognitive ability, autism severity in both domains, and also in adaptive skills. Regarding early toddlerhood behaviors and outcome, better cognition and less severe autism symptoms at toddlerhood were associated with better outcome. Specific early social communication behaviors distinguished between the group, and we mentioned them, the frequency of vocalization, the facial expression, pointing, showing, and response to joint attention. And better early interest, we think that better early interest in reciprocity and in social engagement enable better improvement in social communication skills. In terms of comorbidities outcome, the optimal outcome group had the lowest prevalence of significant inattention symptoms and lowest rate of ADHD diagnosis. The high-functioning ASD group had significantly more participants with severe symptoms in at least one anxiety subtype, than the best outcome group. And the presence of significant inattention and anxiety symptoms in the high-functioning ASD, we believe, may reflect more complicated disorder that may be more resistant to intervention, and that's why maybe we see this picture. And regarding birth risk factors, medical condition, and abnormal neurological examination, again, as I told you, the percentage of ART, prematurity, developmental regression, macro and microcephaly, and family history of ASD were higher for the entire ASD population in the study than the reported frequencies in the general population, but there was no difference between the groups whatsoever. And these findings point to the possibility, possible etiological, birth risk factors, and family history of ASD have for developmental of ASD, but surprisingly, these variables seem not to be related to the clinical presentation and progress along the years. And I want to show you one of the kids we saw, the best outcome group. It's in Hebrew, sorry. So he was talking to the Alutaf therapist, and told them how much he appreciated their contribution to his success. Okay, and final conclusion, very early developmental abilities, social engagement, and communicative behaviors seen in toddlers with ASD have good prognostic value for outcome in adolescents. The relative low explained variance, the 27% only, for membership in a specific outcome group found in this study points to the difficulty in identifying measures that are associated with outcome. So I am asking the question, does this mean that the vast majority of variability in outcome is not only explained by early measures of toddler characteristics? And do numerous variables and life events that occurred during this long period of follow-up time have a role? We still don't have an answer to that. So I'd like to thank you.